topic is behavioral health treatment for adolescents with opioid use disorder. Given the time frame, this is going to be very much a big picture introduction, but I do hope you'll let me know if you have questions where we can delve into the details or if you'd like support with getting some training. In terms of disclosures, I don't have any financial arrangements related to the content of this activity. For our learning objectives, we're going to discuss approaches for treating youth with opioid use disorder, specifically that build rapport and improve safety. We're going to identify evidence-based behavioral treatments for opioid use disorder in youth. And we're going to look a little more closely with the mechanics there in reviewing the role of psychosocial support and reinforcement in the treatment of youth opioid use disorder. And when I say reinforcement, I mean that in the behavioral health context, which means an activity or experience or behavior that's experienced as satisfying or pleasurable or otherwise rewarding for the patient, which is going to make them want to repeat that. And I'll expand on what that means and the sort of implications for treatment when we get there. So I wanted to start on the front end talking about risk factors, thinking more from a sort of preventive stance. And this is specific to adolescents and transitional age youth, although of course that also means by extension that it applies to adults. And one of the best established risk factors that we know about for OUD is having multiple adverse childhood experiences or ACEs. If you're not familiar with the term ACEs, it encompasses a sort of umbrella of potentially traumatic experiences that people might have before the age of 18 that are likely to disrupt their sense of safety and attachment and therefore result in some degree of traumatic stress. Some of the ACEs that we see most often in this population are childhood abuse, which could be sexual, emotional, or physical, and that can have sequelae across the lifetime if it's not effectively treated. And then, of course, family history of substance use, particularly parental substance use, low parental monitoring. Probably everybody here knows that chronic pain goes along very closely with OUD. More recent literature with LGBTQ plus youth have shown that family rejection of sexual orientation or gender identity is a strong predictive factor for OUD, especially if it disrupts safe housing. So if the child feels compelled to leave the house or is forced to leave the house, that's a particularly strong predictive factor for developing OUD. Of course, association with substance using peers, and then also these constructs called lack of school connectedness and then low academic achievement. And I want to note, I think those sound a little innocuous next to the other ones, but it would be hard to overemphasize how many patients I've seen in this population who have either undiagnosed and or untreated learning disabilities. Quite a few patients who are close to illiterate, by age 16, 17. And I think it's important to remember that even though these seem, perhaps not as dramatic as some of the other risk factors here, when we think about how much of a child's life school takes up and the kind of fear and shame and humiliation that children feel if they're going to school with an undiagnosed learning disability and really, really struggling and probably not really understanding why they're struggling, we can imagine why they would be really looking for a way to experience some relief. So that's my plug for early assessment and screening to make sure we get children the services they need as soon as possible. So a point that I wanted to touch on for this presentation, it's very multifaceted, so this is very big picture, is the idea of the way that opioid use disorder can be established and maintained within a family system. And one of the primary mechanisms there is intergenerational trauma, which is to say when a traumatic event happens to somebody, up the line in the family, perhaps a grandparent, and then the way that they enact that trauma means that it's transmitted throughout the family, perhaps to parents and then children, both in terms of how the symptoms are modeled socially, and then also, of course, the genetic component. So if we take ACEs, adverse childhood experiences, as kind of standing for what we know to be a high prevalence type of trauma or category of trauma, we know that ACEs disrupt development of brain circuitry specifically that's associated with attachment and social bonding. And that happens because when children are under a high degree of chronic stress, the brain is going to reroute resources away from what we think of as the sort of healthy, typical tasks of a developing child, which are learning, playing, growing, and especially forming positive social bonds. And it's going to redistribute them towards essentially survival tasks, more kind of fight or flight tasks, at the expense of those, more pro-social features. So one of the results of this is that people who experience this trajectory often end up with reduced feelings of pleasure and reward from what we would call pro-social natural reinforcers. So specifically here, we're talking about nurturing relationships. So it's not just that they're less likely to have these in families that are impacted with opioid use disorder. It's also that when they do have those, they sort of get a little bit less out of it because their brain is attributing less resources there. So one of the outcomes of this is that then when they try an illicit substance for the first time, specifically opioids or more specifically opioids, that can really simulate the feeling of reward and pleasure that they have not been getting, and their brain is particularly vulnerable. You can think of it as being sort of starved for reinforcement. So it's going to be more potent for them than for a child who has had a lot of other alternative pro-social reinforcers that have kind of built up that buffer for them. This is particularly insidious with opiates because we know that they mimic the endogenous endorphins that are involved in attachment. And it's really striking in the qualitative literature how often you'll see people who have been addicted to opioids talk about how the first few times they used it, it felt like, the hug from the mother that they never had, or, like a warm blanket being put to bed at night. It's really described in these very relational terms. So for some people, this might be their first experience of something that feels like love and connection. And unfortunately, it's a false one. It's unsustainable. So what we know is that parents with substance use disorders and multiple adverse childhood experiences, they often exhibit deficits in really key parenting skills, including things like understanding their children's emotions and behaviors and being able to respond effectively and sensitively to children's cues. And also just the general ability to stay present and focused with a child, which particularly young children, even if they're not able to verbalize it, that tends to cause quite a lot of distress, whether it's overt hypervigilance or a sort of more subtle form of dissociation. Children are aware when their parents are not really there, and that can be quite distressing for them, especially when they're young and very vulnerable. So one of the outcomes of that is that often this compromises their own development of capacities for attention, for executive functioning, for relational attentiveness, so that further commutes their options for forming positive social bonds even outside of the caregiver relationship. So I know this is a lot of moving pieces to put together in a short amount of time, but the sort of big picture there of the vicious cycle that can happen is we know that insecure attachment, so that, a disrupted relationship between child and caregiver, that in itself is a prime risk factor for substance use disorders generally and opioid use disorder specifically. And then we also know that if somebody then proceeds to use substances, especially chronically, that then further impairs the ability to establish and maintain close relationships. So we often see a lot of isolation in these families, families that are only or frequently interacting in negative terms and not having a lot of positive experiences or bonding with each other. And the reason that I touch on this as we talk about treatment for this population is that it doesn't always work out, but whenever possible, we really want to involve the caregivers or whatever the social support network is in treatment, not only because it's going to help the patient succeed, but also because that's the best way to reverse this cycle, right? If we can help the patient to succeed and get into recovery, that's really breaking the link of the intergenerational chain there. But in order to start a reparative cycle and to change the dynamics within the family to support their recovery and everyone else's, it's really important to give the caregivers support and skill building as well. So in addition to working with the family system, there are some particular challenges that go along with treating young people with opioid use disorder. The general mechanics of treatment are very similar between young and adult populations, but there are some unique developmental challenges here that warrant some extra resourcefulness. One of the key ones is brain development. Probably, most of you here know that there is this sort of hallmark of adolescent development where the prefrontal cortex, which is sort of decision making, judiciousness, being able to think about and plan for the future, that really lags behind in development compared to the limbic system, the area of the brain that's responsible for sort of big, showy, flamboyant, reactive emotions, fear and anger, and also positive valenced emotions, but primarily the negative, distressing ones. And so when we think of that kind of asymmetry, that there's just a lot going on with big feelings and not a lot up front in terms of executive functioning to figure out how to cope with it. It's no surprise that this age is often characterized by emotion regulation deficits. And then, of course, teens are pretty much known for risk taking, impulsivity, sensation seeking, novelty, and experimentation. That's really kind of a characteristic of how their brains are developing. And unfortunately, substance use fits right into that, right? It's often, just beyond the horizon of their everyday experience. And so very appealing in that way. We also know, of course, that teens, more than any other age group, are extremely susceptible to peer influence. And that can be a particularly difficult facet of treatment with this age. Another piece of working with teenagers and transitional age youth is that the family system, ideally is going to be a lot more involved, and that's a good thing, but it does add some complications, of course. One of the most important features of working with families, in my experience, with this population, is helping them to understand how medication for opioid use disorder works, because there's often a lot of stigma and misinformation. And you can understand from a caregiver, loved one's point of view, they're worried about what this signifies for the teen, the child. They have a lot of fear about the future, about what it might mean for who they are now and who they could become. And so a lot of the work on my side with the family system is challenging misinformation, making sure that they have accurate scientific information about what medication for opioid use disorder is and how it can be helpful. I borrowed this slide from Dr. Hayes. I wanted to make sure that it was prescriber approved. So this is the official position statement from the Society for Adolescent Health and Medicine, and they say that all adolescents and young adults with opioid use disorder should be offered medication for OUD as a critical component of an integrated treatment approach. So in other words, there's no kind of special exception for teens or for transitional age youth. We know that the same life-saving benefits apply to them as it does to adults. And in fact, because treatment retention is so much more difficult with younger populations, it actually has that additional benefit even more so. And I wanted to point out, I added a link at the bottom there. The American Academy of Pediatrics has their own ECHO series actually on buprenorphine induction for adolescents that's free and on demand, if that's something you're interested in. I wanted to share a graphic and just sort of an elevator pitch that I often use with parents. So I want to be clear, I know you all understand this, but I want to give a demonstration of how I talk to the social support system and the patient about MOUD when they're worried about it. So using this graph, I would share, in the acute phases when somebody first starts using opiates, they're often bouncing back and forth between the sort of normal functioning range and euphoria, being kind of too high to function. And then very quickly, as tolerance develops through chronic use, they're going to descend into this vacillation that's really more between withdrawal and normal functioning, where the primary function of use is really more the negative reinforcement, trying to get rid of the symptoms of withdrawal. And this doesn't leave a lot of bandwidth, obviously, for accomplishing the important tasks of everyday life. So what the medication does, as I explain it, is once it's accurately calibrated to that individual, is it smooths out these really precipitous ups and downs into a nice, slow, steady wave that stays in that normal green meridian. And that allows the patient the bandwidth, the psychological and the physical resources to be able to concentrate on recovery. So it's, above and beyond keeping them safe, and that is the first task. It's allowing them to build a life that's worth living in recovery and repair some of the damage that's been done to their social resources, perhaps their physical health, et cetera, through their use. So thinking of the primary functions of psychosocial treatment for this population, just reiterating, supporting medication adherence really is one of the very top tasks that I do with this population, and it's an ongoing one. I find that with younger adults, especially if they're at a clinic where the clinic is combined with an adult clinic, there's kind of these constant reminders that they're experiencing something that's very different and very negative compared to their peers, and that can make attrition a lot more of a factor. This is one of the reasons that I think every prescriber I've worked with this population has moved as quickly as is indicated to get teen patients onto injectables whenever it's possible, because we'd want to make it as frictionless as possible. And they particularly don't like to come to the clinic and, have other sort of lifestyle objections to keeping up with medication. On the more explicitly therapeutic side, the first task of treatment really is about keeping them safe. And with teens, this tends to move more slowly than with adults. They're just not old enough yet that the consequences have caught up with them to the degree that adults have with the same disorder. So the ambivalence tends to be stronger. And that means it's really important that we meet them where they're at. So overdose prevention is absolutely the first task. We talk about how to keep them safe if they're going to continue to use. And then we start to segue, once rapport is built and treatment is on steady ground, into relapse prevention, recovery planning, skills, and education. An ongoing thread with this population really is about motivation for treatment. And that's not just the patient, that's the family too. Everybody involved, obviously, teen patients are in a hurry to get where they're going. They want recovery to go as fast as possible. And the same really goes in a sense for the family. They're really anxious to see this child succeed. And then, of course, the sort of ongoing facet with treatment is, beyond treating the substance use disorder specifically, we always want to address underlying contributors. So that could be explicit comorbidities. It could be about family dynamics or social influences that cause stress. We want to make sure that the patient understands what made them vulnerable in the first place and how to protect themselves to reduce that vulnerability in the future. So when I spoke about that importance of building rapport and increasing safety at the beginning, I want to talk about just some broad trans-theoretical strategies here that I think providers of all type can use. The first, the most obvious, is overdose prevention, of course. So we always want to make sure that they have Narcan and that they know how to use it. We want to go over just kind of the basics of how to reduce risk. So things like refraining from using multiple substances at once, knowing their source. If your clinic is able to provide test strips or you can direct them to an organization that does, we want to make sure that they know how to use them accurately because they tend to default to using them as though they are pregnancy tests. They usually don't act the same way. And then test shot or analogous strategies depending on their route of administration. The idea being that we wouldn't want them to start with the highest dose that they think that they would want, but rather build up to it so that they can get a sense of the potency of the substance. As far as injection practices, I'll knock on wood and say I have seen very few in this age group who inject. It's mostly smoking, but obviously, if you are working with a patient of any age who's using intravenously, we want to make sure to go over safe injection practices with them. And then some of the psychosocial facets, so controlling the environment, things like, picking the right spot, being around familiar and trusted people who know where you are and what's going on, and that you don't lock the door or lean against it, making sure they're familiar with resources like the never use alone line if they don't have somebody in their life that they're able to, have there present for them. And then adjusting routines is this sort of intermediate ground where we're moving from those really basics of how can we make you as safe as possible if you're going to continue to use, to laying down some groundwork skills that eventually become key in relapse prevention. So starting, of course, with route of administration, anytime we can sort of reduce their risk level, we want to do that. In the resources section of these slides, I have a little sheet that I go over that goes, sort of details what the different routes of administration are and how long it takes and what the different risks are so that we can talk about how to reduce risk there. And then, of course, frequency and dose, anytime we can chip away at that, could you use less or less frequently? That's a really good start. And that leads us into distract and delay skills. So those are skills around, if you're going to use, you're going to use, but do you think you could wait even a minute longer? Do you think you could take a walk around the block first? And those eventually can be parlayed into very, very valuable relapse prevention skills. And then, of course, adult times, we want to make sure that we're offering the psychoeducation, the resources that are going to be relevant, not only to the patient, but to the family. So in terms of the evidence-based treatments for young people with opioid use disorder, this is really just a list. We don't have time to dive into the mechanics of each one of them. I did want to note, we talk about contingency management not infrequently on this echo, and there is evidence that contingency management is actually more effective for young people than it is for older populations, most likely because of their sensitivity to immediate reward. So that's something, if it's available to you, and particularly if you can pair it with one of these formal structured treatments, because we know that's the sort of best mileage, definitely don't pass up on that. And then for all of the evidence-based treatments, they're going to have some element of cognitive behavioral therapy or something reminiscent of it, because that's sort of the framework for relapse prevention. There's been an exciting development recently that combines a CBT approach for chronic pain with OUD, which is obviously a very good thing. Historically, they've often been treated sort of in parallel, which is not as efficient. Motivational enhancement therapy does not specifically target OUD unless it's adapted, but it is one that's very valuable because, particularly as I've mentioned with this age group, motivation we expect to waver and wane a lot across the course of treatment. And we can almost always conceptualize these patients as being to some degree mandated because it's almost always the support network that brings them in. Not always, usually. Structured family approaches is an umbrella for several different types of therapy approaches that involve the family, and we know that those are always superior to individual solo treatments. So that could be everything from brief strategic family therapy, which actually is pretty quick and is very focused on skill building, to multisystemic therapy or MST, which is this comprehensive wraparound, involves the school and the neighbors and goes on for, half a year. But we do know that anytime we're involving the family or the social support system, the patient is more likely to do better and recovery is more likely to stick. I want to mention peer support because it's not something that we're often thinking of as a psychosocial treatment. And it's not, obviously it's not the same as a formal structured treatment. But in my experience, if you can find a youth peer support worker in particular, that can be an absolute game changer. It's so important for this population where they often feel like they're the only one going through this, to see somebody who's even roughly in their age range, who's even within 10 years of them, who's made it out to the other side and can be a model of, you can still go on to have a really good positive life. Now, the one that I'm going to just focus on for a few minutes to sort of illustrate the mechanics of treatment are the adolescent community reinforcement approach, ACRA, and then its complementary format, the community reinforcement and family training approach, that's CRAFT, because it was sort of one of the first both individual and family treatments for OUD, and a lot of the others have built off of it. So the community reinforcement approach was originally developed for alcohol use disorder and then later was adapted for other SUDs and for the adolescent population. One of the most important distinctions about it is that for its era, it was one of the very first to move away from explanations of addictions that were rooted in spirituality or morality and that tended to attribute the problem to essentially willpower or character, and be instead expressly rooted in science. In this case, it's based very much on behavioral principles, and you'll find that in most relapse prevention, any type of OUD treatment. And specifically, it really provides a lot of psychoeducation and training for the patients around classical conditioning as it pertains to how triggers are formed and maintained, operant conditioning in terms of how they can learn to manage their behaviors and enact coping skills differently, and then social learning in terms of the context in which all of these therapeutic activities are embedded. Now, the express goal with CRA and CRAFT is that we're trying to cultivate positive reinforcers in the patient's environment that will eventually outcompete the substance use. And I want to acknowledge, when I first heard about this program, I thought that sounded really naive. And I probably still wouldn't believe it if I had not seen this work so well with so many difficult cases. But really, the idea here is that we're trying to reverse that process of reinforcement where the substances are the only things that are feeling rewarding for the person, and sort of create rich and voluminous and potent enough natural reinforcers. So again, those are things like positive nurturing relationships, hobbies or work or school or whatever it is that feels meaningful and interesting and helps the patient reflect their own strengths to them. Anything that feels enjoyable and engaging, and that is not artificial, that does not come from a substance or is not otherwise antisocial. And then, of course, the program also includes quite a lot of skill building around prominently relapse prevention and recovery planning. CRA was also one of the very first to be formally paired with contingency management, and there's really great evidence for that approach, especially. So one of the things as a clinician that I really like about this approach is that instead of splitting it up into an individual and a support system approach, is that there's one for each and they're built to be complementary. So CRAFT is the complementary component. It's built for what we call the concerned significant others, or CSOs. Most often we think that's a parent or caregiver, but I've worked with neighbors, teammates, et cetera, as it really can be quite adaptable. And that's because of course, especially for a young patient, their psychosocial environment is largely structured by their caregivers. But also something that we sometimes overlook is that the well-being of the concerned significant others is very significantly impacted by the patient's substance use. Sometimes even, their well-being might be jeopardized by their substance use, and they really deserve treatment and support as well. So the craft sort of approach combines those, where we're not just doing this for the support of the patient, we're also doing it because CSOs deserve to be supported and have their own skills applied on their own terms. This also harkens back to what I mentioned before about breaking that intergenerational cycle, because if the patient's the only one who's getting the support and the skills, we can't expect them to be the one that changes everything in the family. So CSOs are really important because we know that they're essentially structuring the day-to-day life of the patient. And we know that when they get proper support and training, most concerned significant others are really quite good at learning skills that complement and support the patient's recovery skills. So they're sort of learning them in tandem and getting to practice them together in their natural environment, which is the best way for learning to take place. Another thing CSOs can do is model and initiate positive change. That's again about changing the dynamic within the family, which may have been predisposed to be quite negative or stagnant. And something that CSOs can do that we as healthcare providers are never going to be able to compete with is providing immediate salient reinforcement for pro-social behaviors. So when a patient does something that's an exciting, big, different behavior change, and then they come to my office a week later and I celebrate with them and give them the gold star or whatever it is, there's no way that that can compete with somebody right there in the moment, in their own environment, reflecting to them that they feel proud of them, that they notice the work that they're doing, that it makes a big difference for them and for the family. That's so much more reinforcing. And we know that that's how the best learning takes place. So the quote from one of the developers of Craft is, "No one knows more about the individual's behavior, triggers, and strengths than the people who live in their household." And that kind of summarizes what a unique role the CSOs can play. I wanted just in the last couple minutes to go over some of the interventions here that represent what we usually would find in a family and individual complementary approach for OUD. This is the functional analysis. You're going to find this in any kind of system that addresses relapse prevention. And this is just a map where we look at external triggers, internal triggers. We kind of map out the behavior, and then we look at short-term and long-term positive and negative respective consequences. And this is to help promote insight, as well as to help identify the aspects of the classical conditioning that they've undergone to develop the triggers in order to be able to avoid, mitigate, and cope differently with the triggers as they happen. Any family systems therapy you're going to encounter is going to have some kind of work around communication skills. I really like Crafts. I think it's pretty well condensed. There's just kind of 8 points that we go over again and again around positive communication skills, because we find that in families, and particularly towards patients where OUD is happening, there's a whole lot of negative communication, and we know that most people don't learn very well and are not very receptive to negative communication. And I would say this is the module of Craft that I consistently get the most positive feedback from participants. They almost always say that even if they didn't find it helpful with the patient themselves, that it helped them in their other relationships or at work, et cetera. So this again is one of those, changing the dynamic kind of ingredients. And I think for time, I'll skip the happiness scale because that's unique to Craft, but happy to answer questions about that if you're curious. In resources, these are just some more of the graphics that I use when I talk about MOUD to the social support system. And then this is that roots of administration sheet that I mentioned that I talk over with teens so that we can look at what are some safer ways for them to use if they're open to it.